This is a recorded lecture for Chapter 2 of our Healthcare 400 Healthcare Analytics. And what we're going to look at in this chapter is really the fundamentals of healthcare analytics. What are the component elements that make up the healthcare analytics that we're going to use? First, really, we're going to look at is what's really the effective healthcare analytics? What does it require? And as it says here, it's a comprehensive methodology that allows us to extract information from multiple data sources and allows us to identify a standardized methodology for representing that information to the end users such that they understand what we're talking about. In other words, you want to be consistent in the information as it's presented. It's really important. If you go from one presentation to another about the same data, you want to use the same methodologies, or if you change methodologies, you want to compare the old and new methodologies so if there's any variation, any delta, so to speak, that you can establish that with your users so they don't think you're trying to pull the wool over their eyes, if you will. Effective healthcare analytics is really a process to extract data from our electronic medical records and transform it into usable information for doing quality improvement processes and methodology, for establishing hopefully not a recalcitrant dashboard tool, but a dashboard tool that changes over time, and establish performance measures. So it helps to sort of create this, and that's why the standardization is so important. Now, how can analytics improve decision making? Well, healthcare requires lots of decisions that have to be made, and unfortunately, in today's world, some of that is made without the use of data, but based on emotion and past experiences. So the information that to help decision makers make those decisions has to be informative, and that's that it has to really be able to reveal what's happening now. And then it has to be predictive. It has to reveal what it will predict in the future to happen, and it has to be consistent. I've said this before, the methodologies need to be comprehensive and standardized. You can't have one standard for one presentation, another standard for another presentation. You have to be pretty consistent. Now, if the process, the methodology you're using doesn't make the information fully transparent, then you have to establish a line in the sand that says, okay, this old technology or this old methodology wasn't as effective as it could be. We're going to use this new methodology. This is a comparison of the two. Here's the translator, if you will, between the old presentation and the new presentation. You have to establish that so that your users, listeners, your participants, stakeholders, all those can be the same people, are sure that you're being fully forthright, if you will, and fully transparent in the information you're presenting. Now, healthcare analytics should aid in the decision making, and we say that all the time that we should be data driven, but sometimes and often decisions are made without being data driven. There's no study done or no analytics done to say, okay, if we did this, this is what will probably happen. If we didn't do this, this probably will happen. And so information should be data driven. It should be based on unbiased data that has not been tainted by opinion or emotion. That's a really important point. Sometimes data is translated to people based on what the user really wants them to hear. Like I said, it should be transparent. They should be given open to all and shared, if you will. It should be verifiable. If 2 people or 3 people look at the data, they should come up with the same conclusion, again, without bias or without tainting. And it should be robust. That means the data must be able to be interpreted in such a way that it's usable. If you give somebody how to build a thermonuclear engine and they have no idea where to start, it's not very good information. Where if you set it up like this is step 1, put these things together, step 2, put these things together, then it kind of makes a little more sense. And so it allows the HCO leadership, if you will, to interpret and respond to more of a fast pace and the change in healthcare. Now, when you look at analytics, quality, and performance, analytics should reveal how well an HCO is performing. And that should enable leaders and QI stakeholders to make evidence-based decisions. Now, evidence-based is really that's not a couple of words that are arbitrarily thrown together. Evidence-based healthcare, evidence-based nursing is based on looking at the data, looking at how the different choices panned out in quality care or financial results or whatever, and then it's applied. Not I like the green side better than the blue side because I just like green even though it costs us a lot more, but there's no value. So this should help to clarify and improve understanding of patterns in the data, should identify when and why a change has occurred, and it should give us some logical steps in how we're going to make difference or make what we're going to do in the future to either correct for that what has happened, which if it's bad, or to continue the process if it's good. So we want to make sure that analytics and quality and performance work hand in hand. Now the differences with analytics is analytics are far more graphical, mathematical, and statistically focused, which helps the data be more predictive, if you will. So analytics is really more robust, it's more volatile, has more texture. Most standardized reports and dashboards are usually based on somebody's idea of what you need, what the leadership needed to see, sometimes even leadership, if you will, and then many, many years later, the same information comes across even though it's no longer applicable. I'll never forget, we used to get this data when I was an administrator at a medical center. And we would get this data, and I look at this data every day to be the same answer in this one area every single day. So we get this report every day and every day. And finally, after about the 5th day, I'd been the administrator for a whole week, I said, well, this data is the same. Can you tell me why this data is the same? And the answer was, well, this unit isn't open anymore. So my question was, why do you report it? Well, it's part of the dashboard, and everyone wants to see it. I said, well, if it's not there anymore, why are we reporting it? So a lot of things become really recalcitrant or really stabilized in a dashboard, and so that has to be as movable as everything else. Now, I want to look at this. This is a healthcare quality performance, and there's 4 really areas when you talk about reporting and analytic capabilities, if you will, and quality improvement and performance improvement. And there's really 4 areas. And the first area is really, you want to know is what's occurred. You want to be able to analyze what's happened, good, bad, and ugly. What's the truth? So we can work with it. Not what we want it to be, what is it? And then you have to say, well, what's occurring now? If this has occurred, has there been a change? Is there a delta between this event and what's happening now? And if there's different now, why is that so? And then the third question is, why is that occurring? The question is, this question is multifaceted. It could be, why did this occur? How did it course correct, and how did that happen? So you have to look at that too. And then finally, you have to say, okay, is this ever going to occur again? I'll never forget, I came into a place, and I was a consultant, and the leadership had something happen, and I forget what it was, but they had made a whole track of checks and balances to follow this event. This event had occurred once in 100 years. Okay, literally, this organization had been open and working for over 100 years, and it occurred once in 100 years. And the analytics predicted it wouldn't happen again. The chances of it happening again are 1 in 100,000. And yet they had these multiple checks and balances that resources were being applied to ensure that it never happened again. Even though it was what most terrible events are really a conglomeration of 5 things going wrong at the same time. And so they put these things in place without ever thinking about what the value was. It was just their sort of knee-jerk response. Now, analytics for QI and quality improvement and patient improvement, if you will, it should be reports and dashboards typically provide the information in circles 1 and 2 of the previous figure. That is what's occurred and why is it, or what is occurring, what has occurred. And it's usually historical data. It tells what has occurred and what is occurring now. Where circles 3 and 4, why is it occurring, what is likely to occur, are where analytics facilitate understanding why the data is the way it is and how it is predictive of what can happen in the future, and whether we should respond to it based on data or whether we can say, okay, it was an aberration, we'll move on. Now, you look at applications of healthcare analytics, we have multiple ways we look at that. We can look at it for process and workflow improvement. We can eliminate barriers to quality and waste in process and workflows. You would be surprised when people will have workflows set up, and those workflows will be in place for 20 years. And the technology will have changed, the people will have changed, the layout of the room will have changed. They may be in a whole different area of the hospital, the healthcare organization, and yet the workflow is the same based on that. So what do people do when the workflow isn't logical? They start to short-circuit it. They shortcut it. And so the workflow that turns out may be different. What makes it worse is the workflow is different from person to person because there's no reassessment of how it should be standardized. So what the manager thinks is happening is not really what's happening. And what each of the people in the process are doing is different from one or the other. There's an old saying that the more variation you have in a process, the more likely it becomes sort of incrementally or logarithmically different. If you have two different ways to do a process, then your chances are 10 to the second that something will go wrong. If you have three, that's 10 to the third. So it really increases exponentially. So you have to eliminate those barriers to quality, waste, and process and workflow. And you have to determine what you need to improve and how to improve it, not based on emotion, not based on the flavor of the month, which is my favorite term, but based on what will do it the best way, will become more, what will sustain the result. In other words, we often put little patches on things that break again and again. I always, my sort of anomaly, or my sort of metaphor for that is that, you know, it's like taking a cardboard patch and putting it on a high pressure water hose. It may hold for a few seconds, but not very long, and you keep putting it on there. What you really need to do is maybe replace the hose, which is more expensive, but will save you all the time it does to keep doing the patch. So it also should help prioritize projects. Everybody has a project, and some of them are meaningful and some of them are not so meaningful. It's not to say there's not value in the least meaningful ones, but it may not be the biggest bang for the buck. So when you start to develop projects, you should have a clearinghouse that says, okay, these projects have high level financial, these projects are high level patient quality, high level patient safety. These are not there, so these are not in those areas. So if they're not there, they get lower priority. And then the applications of the healthcare analytics should monitor ongoing performance after the improvements have been in place, and that ensures sustainment. The biggest issue in making change, wherever you're at, is really sustainment. It's easy to make a change. You put out an edict, you write a paper, you change the process, and then you have to see if that really happens. And about 9 times out of 10, unless you follow through, unless you measure the outcome, it will go back to the way it was before because people will fall back to that. You have to make the new process more comfortable than the old process was. You have to make the old process, as somebody does the old process, you have to make it uncomfortable or inefficient for them to do that. You have to consistently make sure that happens, and that's really monitoring what you do. This is the area that's least done and the biggest issue in the world of healthcare today. We make these changes and we think, okay, I made a change. I told my children to clean their room. And lo and behold, it's a week later and my children's room is not clean again. Well, so I tell them to clean it again. And we keep doing this process, and maybe I start to yell, and maybe I take some more extensive measures, whatever that is. But the problem is that the room never gets ultimately cleaned. So it's because it's more comfortable for the teenager to not clean it, for the children not clean it for a week or two, and just deal with you not being happy for a day or two or a few hours. So you have to make sure that there's sustainment. Some other things, you have to use the clinical decision support. Analytics can present evidence of the care of a single patient, a group of patients, a whole unit, or the whole healthcare organization. It helps you to make decisions based on the scope of the problem you're looking at. And it helps to disseminate timely clinical information to healthcare providers. We'll never forget this. It was kind of a striking event. I was at the University of New Mexico hospitals, and we were meeting with all the surgeons, if you will, and all the specialties, and specifically the pediatric cardiologists. And that was my area, like one of my departments. And so we met with them. We were looking at the outcomes for their replacement of pediatric heart valves and pediatric surgeries. And we discovered that our outcomes, because we didn't do very many, were not very comparable to, for instance, Stanford, which has a very large and very active pediatric cardiology or cardiothoracic section. And so we decided that we were better off not doing those certain kinds of surgeries in our hospital, but actually paying to send those patients to Stanford to have the surgery done, and then transporting them back when they were stable and taking care of them postoperatively in our hospital. The patient's outcomes were better. We developed a good working relationship with Stanford. Excuse me. And truly, we improved patient care significantly. So a good example is, for example, computerized provider order entry, the CPOE. We can evaluate medical guidelines, and compare ordered medications with established guidelines for adverse drug reactions and drug contraindications. Now this is kind of looking at things in an old sort of way. We have the new technology we have for like easy scripts and computerized prescriptions really automatically does that. It will show you if you use a medication that's contraindicated. And you could still use it, but you have to validate it, it's documented, and that's reviewed at a later date. You can also see if a medication has a crossover or drug interaction with something else. Well, if that's so, you know that's happening, but you can put your justification in, say, I know this happens, but this is why I'm doing it, because maybe I don't have the alternative. Maybe the patient is allergic to everything else, or maybe this is the only thing that's going to save their life, or whatever. And so you have to validate why you're doing that. So that it forces providers to follow prescribed guidelines and not to inadvertently use medications that are contraindicated for each other, have interactions. It also helps to establish protocols for specific diseases or prevent unnecessary long stays in the emergency room. For instance, if you have, well, let's look at tuberculosis, for instance. Tuberculosis has really changed in the last 10 years or 20 years from a slow-growing disease to a much faster-growing disease because of its interaction with patients who are HIV positive or have full-blown AIDS. And that TB has become faster-growing. So the protocols we use for TB in the past aren't really effective in the new TBs because it's a whole different disease. So we had to reestablish those protocols and how we're going to treat them, establish what kind of TB we are, because they can be serotyped and genotyped, to find out if it's the TB that's fast-growing, the TB that's the old slow-growing, and to treat it appropriately. We look at population health management. I like this. I took this right out of the book. I copied it and I plagiarized it, and then it showed I did. It says the coordination of healthcare delivery across the population to improve clinical and financial outcomes through disease management, case management, and demand management. That's how you manage populations. And what it does is it sort of forces our hand so that we are delivering care not based on what I like to do, but what I should do. And so we look at all the health care, we look at all the patients that, for instance, come in with diabetes. Are they all getting eye exams annually? Are they getting glycosylated hemoglobins quarterly? Are they getting blood sugars regularly? Do we log those blood sugars, and do we review those with the patient? Are we looking at diet on a regular basis? Are we looking at weight on a regular basis? Are all those things happening, or are we just coming in to let them refill their insulin and sending back out the door again? So that's a way we can look at that. It helps healthcare organizations achieve improvements for identifying patient subgroups to better treat high-risk patients, or at least patients that may be high-cost patients. It helps track high-risk patients, determine overall compliance and outcomes. Let's say that you have some patients that aren't monitoring their blood sugar, or aren't taking their insulin, or aren't following the American Diabetic Association diet. It allows you to look at those patients and identify them, and then create a secondary response, another response over and above what you do for the patients that are compliant, and to help change their outcome. I always remember the Loveless Health Systems, which was a HMO, Health Management Organization. And though that's gotten bad press, it was a very good system in that it was very good with preventive health care. And they were one of the top players in the nation as far as post-operative care of a CABG, a coronary artery bypass graft. And then because they would follow patients very closely and ensure they did the rehabilitation and all the testing and all of that. They were almost, it's kind of like the mafia, to be honest with you. They would go to people's homes and they'd make sure they were walking, and we had health givers, if you will, or on-site health givers who would go to their house, would actually go walking with them, would take them through the first day or two after their CABG was done, after they got home, would help to show them how to fix their food. And all that sounds really expensive, except the recidivism rate, the recurrence rate of people that have CABGs done, coronary artery bypass grafts, because they don't follow through, is very high and very expensive. So this health organization found it was much cheaper to really hire people to go to these people's houses and sort of browbeat them, for lack of a better term, or to show them, to teach them how to take care of themselves. And their outcomes were like 40% better than across the nation. And it turns out the cost of doing business for all those people, and usually it was about 8 or 10 people that went out because they had a pretty large clientele, So all those people may have cost them, you know, somewhere around, let's say, $25,000 a piece, so $400,000, but they were saving over $8 million in recidivism costs of these patients coming back because they didn't follow through. So pretty important. Now, the other application is payer risk analysis and fraud prevention. It can transform medical claims payment system into a reduce improper, erroneous, and fraudulent claims, and they cost you money. Claims that are fraudulent cost you money, one way or the other. Either the payers come back and they sue you, or the payers come back and they fine you, if you will. For instance, Centers for Medicaid and Medicare, they found $4 billion in recoveries because of fraudulent detection abilities in their data analytics. $4 billion, and that's a year, by the way. That's 1 year. So it allows a breakthrough of traditional barriers and silos, so it forces people to really sort of adhere to the letter of the law, not just change as they want to. And they can't hide much. So the components of healthcare analytics, the input must include the stakeholders. And by stakeholders, you mean patients and staff and managers and senior leadership or whoever, the political people who play, the city that the healthcare organization is involved in, the religious group, if that's part of it. I mean, everybody that's involved. And the output must be utilized by leaders, quality improvement teams, and other decision makers, so they use that data to make decisions. And the Forrester Research's business intelligence stack said you have to look at all these things: infrastructure, analytics, data, performance management, supporting analytics, and discovery integration. All of these were part of establishing a well-contrived, well-nourished, if you will, really a rigorous business intelligence approach, so that you can ensure that you're giving the best quality care, you get the best bang for the buck and the best dollar. Now, this is a good look at a sort of an analytics stack, and we kind of talked about this. And it starts out with that business context here at the bottom, where it looks at objective and goals and the voice of the patient. We'll talk about that in a minute. The data includes quality and management, integration, infrastructure, and storage. And the analytics looks at tools and techniques and the teams, if you will, and stakeholders, the requirements to meet the demand, deployment of the information, as well as deployment of the resources, management of the resources, quality and performance management to include processes and indicators and targets and improvement strategies and evaluation strategies. And then finally, presentation. Can the information be visualized? Are dashboards robust? Are they going to show some data that hasn't been necessary to see or has been archaic and not really applicable for 10 years? That's still going to show that. Are there reports? Are they standardized, and are they significant? Are there alerts that say, you know, danger, danger, watch out for this? Are they mobile? Are they only stored in one place and nobody gets to see it? And last, are they geospatial? Do they take into consideration our external stakeholders as well as just more than just the internal stakeholders, the people inside of the healthcare organization? Now, the basic layers of analytics for performance and QI we said was business content layer. That applies primarily to quality and performance goals. It should include the voice of the patient. It should be consistent with and correlate with the healthcare organization's objectives as established by the strategic plan. And that's a whole other conversation about how we develop strategic plans in healthcare organizations and put them on a shelf and ignore them. The goals and objectives should drive the requirements. So the goals and objectives of our strategic plan should drive this requirement. Now we look at the data layer, if you will, the next layer, excuse me. It represents quality, management, integration, infrastructure, storage. And the aspects include these areas. It should include the data sources, for instance, electronic medical record, the financial systems, our supply chain, all those data that we have is put that together. It should be an operational data store, which means that's kind of an intermediate data integration site. So you kind of collect this information and sort of fabricate it so you can use it again. The enterprise data warehouse, that's to clean, transform, and integrate information so it's now usable. And then an analytics sandbox, that's really a place we see data that's in a kind of a lower level data access level, and allows us to easily pull data out for faster analysis and queries, if you will. And then integration, which is combining sources from the electronic data warehouse, and it helps us to create visualization, so we create processes that allow the decision makers to make decisions. Now, the analytics layer the tools and techniques that analytic teams use to generate information starts out with an online analytical processing. That's the company data sets that are pre-aggregated and stored in these multi-dimensional formats, and it supports the drill down and roll up and slice and dice. Drill down is just what it sounds like. You drill down to the smallest data elements, and then you look for congruity, or you look for consistency or reproducibility. That enables the user to obtain and navigate through additional data to drill down to the smallest layer, if you will, and say how many patients in our organization, how many diabetic patients are getting annual ophthalmic evaluations, period. So we don't know. So that's a really piece of small data. How many have normal glycosylated hemoglobins, which is how you look at long-term blood glucoses for patients? How many have those? And you look at that. Roll-up is a little different. Roll-up is the opposite of drill down. It's a consolidation of data. So you look at not just one person or a small group, you look at the hospital as a whole. Our hospital compared to hospital B has this comparison as far as this data. Then slice and dice. Sometimes you'll see those in what are called pivot tables in Excel worksheets. That's where you can change things around and sort of filter things from one level to the other, from using one driver to the other. And it's a really handy thing. If you haven't used a Excel pivot sheet, you need a pivot table. You need to think about doing those. You put the data in, especially a lot of very sophisticated technical data. You put it in, you start finding out what's happening based on one driver. So you can say, okay, everybody who drives a car that works in our hospital has this outcome. Everybody who doesn't drive a car has this outcome. Everybody who drives a motorcycle has this outcome. You can start comparing those things based on what your data input is. Part-time employees versus full-time employees. Hourly employees versus salary employees. You make all sorts of decisions. Now, basic layers of analytics for performance and QI continued. We can do ad hoc analysis. That's a more complex analysis, more short-term, if you will, sort of ad hoc says, okay, we have a problem we think is coming up. Can you do an ad hoc analysis to see if we're going to have a big problem or a little problem based on this change in documentation requirements by the Centers for Medicaid and Medicare? And then we can look it up. And it relies on non-aggregated data. It's best performed in an analytic sandbox away from the other EDW activities. We can also do text mining. That's where we look through text notes, if you will, nurses' notes and progress notes and such that are written out, and it lets us extract, for instance, comorbidities. We could say, okay, all these people have diabetes, but how many people with diabetes in their diagnosis have these elements, have these other diseases? And so you look for text that says, okay, atherosclerotic heart disease, neurodeficit disorder, any of those kind of things. And you can start looking at that through text mining. Then you have data mining, which is and predictive analysis, which are two disciplines that consist of looking for patterns and trends in data, and it helps to aid in making predictions about future performance. It's just really helpful. Data mining tells you how it's been, it'll tell you how it's progressed or not progressed, and it'll be predictive in many cases about what's going to happen in the near future. Now we can look at quality and performance layer that aligns analytics with processes that need to be improved. And some really good places to look at are the Lean System and Six Sigma strategies, and they're considered this layer. You'll hear Six Sigma, Lean Systems. You can look at rapid process improvement, RPI. You can look at TQM, Total Quality Management. All of these kind of fall in here. They include an analysis of processes, looking at workflow documentation. Indicators. Those are indicators that say, okay, we've established these are the things we want to do well, or these are the areas we want to improve on. These are indicators. And targets are what you're looking for. So I would like all patients to be, if they're going to be brought into the hospital and they're going to be discharged, say they're going to be discharged. I would like all discharges to occur within 4 hours after the doctor writes the discharge orders. Well, okay, that's the indicator, discharges. And it says, what's our targets? 4 hours. And so then you can start to identify how many patients met the 4-hour criteria, how many didn't, and if they didn't, what were the extenuating circumstances, and how can they be eliminated? So we can have improvement strategies. Describe how HCL intends to address quality performance issues. If we're supposed to get it done in 4 hours and we're getting it done in 6 hours, how do we get it done in 4 hours? And what are the things we have to do? Well, we go back to workflow processes and see if there's anything that's not value added, if there's steps that don't really add anything to the outcome. And then we can look at evaluation strategies. Okay, that we've done this change, and then we have to monitor that change to ensure that it's consistently done. So like I said before, sometimes we make changes and we say, okay, we made this wonderful change, it's done, and the people don't do it anymore. So you have to really sort of kill the old way and make sure the new way is the only alternative. And if you have somebody that's doing it the old way, then you have a methodology to identify them, retrain them, and then if that doesn't work, to help them look for another job where that's not required anymore. That's kind of funny, but that's kind of what you do. And so the process is to really follow that. And lastly, conclusions are all components in analytics have to work on a comprehensive collaborative fashion. That means all players, all stakeholders really need to play together. It can't really be used to sort of say, to point fingers within the system. You have to look at it in a quality improvement way. A good example of this is I was in charge of the emergency room. Actually, I was an executive director, administrator, and the emergency room was one of my players, one of my departments. And the department chair, every so many years they would come in and do an analysis of the payer, how we were collecting money and things, and all those kind of things in our system, and to make sure that we were meeting all the state and federal guidelines. Well, we had just redone a whole bunch of processes in this ER, and we were trying to maximize our revenue flow and to minimize our work, the work that we had to do that wasn't value added. So we just done that. So we went to the people and said, we'd like you to come into our emergency room and please go through an analysis. And they were like dumbfounded because most people like try to get out of it, and they try to get away from it. They put them on hold all the time. And so first of all, and then what the second part was, when people come in, they almost never let them look at anything. We gave them tons and tons and tons of data. We just filled up their desks. And so then they did their analysis, and they, of course, presented it to the CEO's meeting, the CEO meeting. And when they got through, they said, we have no suggestions for improvement. And my director of the ER was kind of angry. He says, are you telling me that we had you go through our organization or our department, with a fine-tooth comb, and we asked you to look at everything that was there, and you came up with no suggestions for improvement? We wasted all that time, and you found nothing that we could do better. Well, that was kind of dumbfounded the whole team, because the whole CEO's team, because most people were like trying to find excuses for why things were bad, and we were in the process of trying to find things we could make better. And so it was non-attributional. We weren't trying to find people to make them scapegoats. We were trying to make it improved. And so that's a different way to look at it. So, by the way, everything you do, decisions should include an analytic strategy. It should be a data-based or a data-driven process. Also, your analytic strategy should be in line with your healthcare organization's business and quality improvement strategies. I'll never forget that one of the strategies, or one of the goals for a department, I forget what it was, but it was in contrast to what the organization wanted to do. So they were putting these goals in which didn't support the strategies for the healthcare organization. Doesn't really work. And so it has to be supported by senior leadership. Doesn't really do any good if you have these strategies and senior leadership says, well, I think we'll do that. Not really helpful. And then all the components should be vetted and reevaluated on a regular basis to meet that constantly changing environment that our healthcare organizations are facing. Just like that dashboard that had that piece of information about a department that didn't even exist anymore, but was just left there because nobody touched it. That shouldn't happen. That kind of information should be expunged and taken away, or at least stored in some fashion, but it shouldn't be part of the day-to-day reevaluation, because you look at that and you make decisions based on this constant that isn't even a real constant. It's not really robust, usable data. It's really archaic historical data that is unchanging. It doesn't really help you. And so you want to be able to do that. So that concludes our Chapter 2. Thank you very much.